Hello there, this is Kamran Gopal and I'm here with some questions about the overactive bladder or urgent continence station. We've already done the history for this station and you can have a look back for the history. They might ask about the examination, which will be similar to the stress incontinence examination. The steps are more or less the same: abdominal examination, PV and speculum exam, leakage on coughing and atrophic vaginitis, estrogen status, and looking for urethral diverticulum, cystocele, etc. You can also check the pelvic floor strength using the Oxford grading scale. But it is more important to say in the stress incontinence because that's where your pelvic floor will be weak. Investigations wise, in urgent continence or overactive bladder, you've got the ICIQ OAB and ICIQ UI, so both the overactive bladder and the urinary incontinence questionnaire, and a bladder diary. Then urine dip, MSU for microscopy and culture and sensitivity, a flow test, and a post-void residual and second line urodynamics can be used. Ultrasound, KUB and flexible cystoscopy are not recommended in NICE guidelines, but can be considered in patients with red flags, and also pad testing can be considered as a screening tool for incontinence. As I said in my previous video, that there's a 1 hour ward test and 24-hour home test, and I told you the values: 1.4 grams and 8 grams. Then treatment options, you've got conservative medical and surgical again, conservative lifestyle changes, which is weight loss, smoking cessation, modification of fluid intake, then bladder retraining and pelvic floor exercises both, and topical estrogen if there's any atrophic vaginitis. Medical management is, your first line is anticholinergics such as sulfenacin 5 milligrams once daily, which can be up to 10 milligrams. Now they do ask about the risks of or things to consider with anticholinergics or antimuscarinics, which is to avoid in close angle glaucoma, myasthenia, and also patients who've got cognitive issues, and it can also cause dry mouth, blurred vision, constipation. And then second line, you've got beta-3 agonists such as Mira, 50 milligrams once daily, which should be avoided in uncontrolled hypertension and liver failure. They may ask what other anticholinergics you know about, so you need to know a few names, so oxybutynin, tolterodine, trospium, etc. Then comes surgical management. So I always say I would discuss with the consultant and or discuss in the pelvic floor MDT, and we should always have urodynamics prior to giving surgical options. The different options available are: number one, Botox injections, so botulinum toxin A injections into the bladder. Then we've got neuromodulation such as SNS, so sacral nerve stimulation, and PTNS. Then we've got augmentation procedures such as enterocystoplasty, also known as clam cystoplasty, augmentation of the bladder. And then lastly, very rarely done in complex cases, you can consider urinary diversion surgery as well, even in urgent continence. They can ask for consent for Botox injection, which I would let you look at the Bausch leaflets or PDF and make your own way of how you would explain it. And then there's a question of what are the other indications of Botox injections. So you've got idiopathic detrusor overactivity, neurogenic detrusor overactivity, or bladder sphincter dyssynergia. Have a look at my other videos as well. Towards the end, I would also be doing some extra questions which I've gathered in addition to some basic questions that I'm answering now. Those were gathered from my different interview courses that I did, and just to add on to your knowledge after you've read through some basic online sources, etc. So I wish you all the best. I hope you all gain an NTN, and I'll see you next time.